right. I'd like to welcome Dr. Carlin Center, primary care sports medicine doctor with special interests in exercise counseling and prescription, as well as treating sports concussions. She is the director of primary care sports medicine and the co-director of UCSF Sports Concussion Program. Dr. Center earned her medical degree from David Geffen School of Medicine at UCLA with an internal medicine residency at the University of Washington and a fellowship in primary care sports medicine at UCLA. So she's going to be the leadoff hitter today. Dr. Center.
Thank you. Thanks.
You're all set.
All right. Good morning. Thank you so much. It's great to be here. Thanks to the conference organizers, Rhonda and Selena, and the committee for inviting me to speak. I'm Carlin Center. I direct our group of primary care sports medicine doctors, and am happy to be here to talk to you about sports medicine considerations for women and girls. I have no disclosures, and wanted to introduce you to some of the team of us that about a year ago started the UCSF Women's Sports Medicine Center. The QR code is here. We are super excited to kind of have a sports medicine focus for women and girls at UCSF, and please share this with friends, family, patients, if it's relevant. At the end of this talk, you'll be able to list 3 screening questions to ask all girls and women presenting for a pre-participation physical evaluation. List labs to order when evaluating secondary amenorrhea. Define relative energy deficiency in sport or REDS. List indications for a DEXA scan in an athlete. And identify factors that would make an athlete with REDS high risk for injury or illness if returning to sport without treatment. All right, so we'll start with a case. This is an 18-year-old female high school rower who presents for her PPE. You're reviewing her form that she filled out. She has a history of a rib stress fracture at age 16. She has not had a menstrual period in 6 months, and she worries about her weight. She tells you that she restricts her eating during spring season to make the lightweight boat. All right, so if you're not already using the PPE form when you talk to your athletes and do their annual physical exam, I'd highly encourage it. To me, this really helps me make sure I'm being comprehensive and complete. The PPE, as you probably know, starts out with a mental health screen with a PHQ-4. It asks about sports restriction, which I think is a super high yield question for any of our athletes. And then particularly relevant for our female athletes are 3 questions. 1, have you ever had a stress fracture? You know, super relevant, good to dive into that question with folks. The next ones I really like are the questions about body weight, because I think I find that athletes are pretty honest and find these questions pretty approachable. So question 25 is, do you worry about your weight? Question 26 is, are you trying or has anyone recommended that you gain or lose weight? And I don't know about you, but year after year, I'm always surprised by how many athletes, boys and girls, will actually indicate, yes, someone has told them, has given them input about their body weight relevant to their sport. So I think that's always a question that clues me in to sort of check in about that, ask a follow-up question. Usually what I'll say is, tell me more about this. Could you share with me more about this? And, find out a little bit more about what's going on. And I also then will ask them, okay, so someone has suggested that you should gain weight or lose weight, what are you doing with that information, and what kinds of things are you doing? Exploring things like their diet, of course, supplements, drug use, and so on. And then the last section are menstrual questions. So also a real quick way to just screen for amenorrhea. And of course, young people can have irregular periods. We know that, but making sure that they haven't missed a period for 3 months or more. Anyone who has missed a period for 3 months or more really should have some follow-up questions about that. Okay, so this is to get us rolling, kind of get your minds going. I wanted to ask everyone in the audience, when you think of an athlete who has not gotten her menstrual period and who has a history of a bone stress injury, in this patient's case, a rib stress fracture, what might cause this? What kinds of problems would cause this? So I'll invite you to just yell it out. What's on your mind? Like, what are possible things? Reds, yes, red S. Could be red S. What else? I couldn't hear you.
Good morning.
Yes, good morning. Yes, we're just revving up.
Well, I'm thinking, there's low bone density, so you've got not enough estrogen to help with
Yeah.
bone.
Yeah, with bone strength. So
growth and-
exactly, we know bone density relies on estrogen. Most obviously in a postmenopausal woman where estrogen drops, you develop osteoporosis. So in a young person, that can also happen. You can have low estrogen, and there's a variety of causes for low estrogen in premenopausal women and girls. So we're thinking hormone things, we're thinking REDS, which is really a fueling and energy availability thing. There's a list, so a list of endocrine problems, thyroid disease, ovarian insufficiency, so the ovaries are not pumping out hormones, hypothalamic dysfunction, of which functional hypothalamic amenorrhea is the term for the problem that's happening in REDS. The risk factors for that are weight loss, excessive exercise, stress, severe or prolonged illness. Interestingly, traumatic brain injury also can cause hormone issues and secondary amenorrhea. Pituitary dysfunction, such as someone who's producing too much prolactin or someone who has Cushing disease, too much cortisol, polycystic ovarian syndrome, and then of course, pregnancy would cause you to not have a period. Always good to remember. So in our evaluation, first we start off by ruling out pregnancy with an HCG, and then ordering FSH, estradiol, a TSH for thyroid, a prolactin, and then if your patient is demonstrating hyperandrogenism, to think about getting a testosterone. And then I'll usually add some additional labs if the patient's had a bone stress injury. So bone stress injuries and restrictive eating is associated with iron deficiency, so I'll usually screen for iron deficiency. And then I'll usually also get a vitamin D and a calcium and an albumin just to correct the vitamin D, to correct the calcium. All right, so a busy slide, which is honestly a little hard for me to read even on this screen, but this walks us through how we interpret these labs. So I'll just talk about what we most commonly see in sports clinic and in primary care clinic in a setting like this with someone who's a young person who's otherwise healthy, who is very physically active and has had a stress injury. So in her case, her prolactin would be normal. She doesn't have a prolactinoma. Her TSH would be normal. She does not have thyroid disease. Her FSH, so the question is her FSH high or not? And in her case, her FSH would not be high. It would either be low or normal. And so then you look at estradiol, and you say, okay, well, what's going on with the estrogen? And in her case, her estrogen would be low. And so that low or normal FSH and low estrogen means she falls into that functional hypothalamic amenorrhea group. Now, that's not the only thing this could be. It could still be a problem with her pituitary. And so sometimes we will still get a pituitary MRI to rule out a mass. But in many cases, this is functional hypothalamic amenorrhea. In your handout, you can see, the sort of cascade of events. If the labs don't end up that way, there are other things to think about. But in this case, this would be an example of functional hypothalamic amenorrhea due to low energy availability. And what happens is the body really just suppresses our physiologic function to prevent pregnancy and to avoid more energy drain. This is a diagnosis of exclusion. And what's happening is decreased GnRH leads to decreased LH and FSH and then decreased estrogen. What's recommended is if one is not used to treating this, to consult with an endocrinologist. So this really brings us to the whole concept of REDS, which was mentioned right off the top as one of the causes of secondary amenorrhea and bone stress injuries. So REDS, so relative energy deficiency in sport, this used to be called female athlete triad. It's evolved to be called REDS. And what this is sort of the central idea that low energy availability leads to physiologic function problems and impaired psychological function. And the key to REDS is this concept of low energy availability. The clues to look out for in our student athletes, first is BMI. So BMI is not a perfect measure, but it is a measure of body composition. And so folks who are high risk for REDS would have a BMI under 17.5, or they would be under 85% of expected body weight when they're in adolescence. Moderate risk would be slightly higher, so BMI under 18.5. If you're meeting with someone and they have had recent weight loss, or if they endorse disordered eating during their PPE, I think that you'd want to screen further for REDS. And then importantly, the consensus statement on REDS really emphasized that if you're meeting with an athlete and they have a low body weight, but they're like, well, I'm not losing weight, I'm fine. A low body weight but that is stable should not be interpreted as ruling out normal energy balance or ruling out low energy availability. You can have low energy availability and not be losing weight. It's just that your physiological function and perhaps your psychological function is being compromised. So you may not be at your optimal weight. And you may have impaired function and impaired athletic performance if you're trying to compete and train below your healthy body weight. The definition of low energy availability is when our dietary energy intake minus the energy we expend in exercise is less than the body's energy needs. So basically, you need more energy than you're putting in. It can be mild and transient, which is benign and called adaptable LEA, or it can cause health impairments and lead to decreased athletic performance, which is called problematic LEA, and these things are on a spectrum, from benign to adaptable to problematic. Also, and interestingly, there's this growing body of literature about low carbohydrate energy availability. So it's thought to be that there can be athletes who have they may look like their energy availability is okay, but actually their macronutrients are all messed up because, we're very interested in protein. And so sometimes we eat a lot of protein and then just no carbs. And there's actually some literature showing that some athletes suffer from low carbohydrate availability specifically. So if you're seeing an athlete and it's kind of like, gosh, it seems like everything's checking out, they're fueling, well, look at the macronutrients as well. And think, okay, maybe it's a carb problem specifically? One challenge about REDS and energy availability is how hard it is to measure. So it's very challenging. It takes a lot of time and effort to measure, to figure out if someone's in energy balance. It's difficult to be accurate. It involves measuring body composition, which needs to be done in a sensitive manner and should be confidential, and really only shared with people outside of the athlete's family if the athlete consents to that. Historically, it was published that the definition of low energy availability was under 30 kcals per kilogram of fat-free mass per day. That was thought to lead to health problems, but when that was published, it really wasn't intended to be a definition. It was sort of more of a research thing. And so it's been shown over time that this really varies. It's very individual. It differs by people's sexes, and it's variable. So I think this is really an area of evolution in the science of REDS. I also wanted to share this paper with you. This is a paper that came out after the consensus paper on REDS. And these authors really propose kind of an alternative explanation for when athletes come into us with these concerns. So an athlete comes in saying, you know what, I'm just not recovering. I'm just feeling worn out and tired, and I'm not performing well. Is it always about energy availability? And these authors say, you know what, we should take a more holistic approach. You know, this could be about sleep problems. This could be a primary mental health challenge. This could be an infectious disease like mono or long COVID. So, you know, I think this paper reminds us to keep the differential broad when we're, you know, if we're starting with an athlete who has amenorrhea and fatigue and maybe some gastrointestinal problems and some sadness, you know, to start as we do with a whole patient approach and approach that holistically. This is the REDS health model. And so in REDS, you see on this graphic that low energy availability is the hub. And then there are these downstream physiologic problems that are due to this root cause of low energy availability. That's the hypothesis in REDS. And so talking to a student athlete about, well, you know, I think that the fatigue, the GI issues, the stress fractures, and so on could all be due to this low energy availability. And then if someone's not hearing us, or maybe they need a kind of different message, you can also talk to them about performance. And so the consensus group also presented this graphic where really low energy availability leads to all kinds of performance challenges. Trouble with recovery, trouble with you know, strength and speed and so on. So depending on the person, they may hear us when we talk to them about the health challenges, or they may hear us better if we put that in terms of how this is going to affect their athletic performance. And when we think about a patient with these kinds of presenting concerns, whether it's I'm not recovering, I'm really tired, I'm not getting the times that I'm used to getting, I've had these stress fractures and so on, I'm not getting my menstrual period. That could be REDS, it could be, you know, a number of other, you know, concerns not having to do with energy availability necessarily. It could be overtraining syndrome. It can be very tricky to sort that out. The main thing, the main way to kind of rule out REDS is to prove that they are in proper energy balance. So to say, okay, yeah, it seems like they're getting enough energy. And if you've ruled everything else out, there's not an infectious disease, mental health is okay, you know, and so on, you then arrive at a diagnosis of overtraining syndrome. So overtraining syndrome is really like the final thing once you've ruled out REDS. But very challenging, all of it, because there aren't great measurements. There's neither REDS nor overtraining has like a great lab marker or something where it's a slam dunk diagnosis. A note about REDS and para-athletes. So there's concern that para-athletes may be higher risk for low energy availability than able-bodied athletes. This was shown in a recent study on US Paralympians, where 62% reported to changing their weight or body composition to enhance performance. 32% had increased scores on an eating disorder questionnaire, and 44% of the female athletes reported menstrual dysfunction. All right, so thinking back to our case, we have our 18-year-old high school rower. She has amenorrhea, she has a history of a rib stress fracture. Her BMI is 18. She has some restrictive eating. She does not meet DSM-5 criteria for an eating disorder. She had menarche at age 13. Her labs are consistent with functional hypothalamic amenorrhea, and her DEXA has a Z-score of -1. All right, so a lot of information. I thought we would all take a minute to digest this case and turn to your neighbor and talk about, would you clear this athlete to row? So I'm going to give you 60 seconds, and then I'll ask you to report back.
Sorry, we're just doing a quick stress test on this guy. There you go.
right, I'm going to call you back. Thank you. That was great, great conversations. I'm interested to hear about people's thoughts. Would anyone be open to sharing a little bit about your conversation? Please.
So we discussed in our group that you had mentioned she hasn't had a period for 6 months. And with this diagnosis, you had mentioned if you are not comfortable managing this, trying to discuss with the patient.
Yeah.
So that is what happened.
Yeah. Yeah.
And obviously, if she does buy in to the thought about cutting back on exercise and increasing nutritional intake, and potentially if we see she gets a menstrual period, say 2 or 3 months in a row, that'll be like a green light to say, okay, we are making some progress, and then we can review. Disease score, I mean, how long would that take? We actually take an extra scan at some point. We don't really have a consensus.
Yeah, yeah.
I don't know.
Thank you. Thank you. Yes.
We want a little bit more information. She's 18, she's a high school rower, and she tried to get like a scholarship to row because I feel like that also connects with how you would approach it. And then also just I'm kind of thinking out loud, but the fact that she's a rower versus a different sport, I think if she's playing more contact sport, I'd be more concerned with this sport.
Yeah. She were like colliding with people. Like, yeah.
Like rowing, there's no, like it's so amazing, but it's not like super.
Yeah, you're not worried she's gonna like break her femur by being tackled or something.
But it also depends on her position in the boat.
Is she in the engine part? She's the one driving that boat? Or is she a coxswain? You know, because then she's just sitting.
Fair, yeah. So
No, I mean.
yeah, is she a coxswain or is she a rower? Where's she sitting in the boat? Yeah.
Right,
Yep.
so, and I think it can be motivating along with what, is it, sorry. Almost. Along with what Eze was saying, I think you can hold her and not have her participate until she can show that she's having a period again, and all of that, but that can be motivating for her. Because it's like saying, you have to hit these criteria before you can continue with this safely, right? And it does matter whether she has to, you know, she's trying to get into college or do something like that, but they can also know that, you know, and go, okay, you have a year to get this together and we'll still.
Timeline and
Yeah.
gives you a real good sense of what kinds of pressure she's
Right.
under,
Right.
what's her timeline like.
Right.
Yeah.
This is more of a question for the group. So what if this is an athlete who says, yeah, my college scholarship depends on me rowing this season,
Yeah.
and if I do not row, I can't go to college. So you're basically, if you do not let me row, you are basically ruining my entire future, right? Because patients will say that to you.
Yeah. Yeah.
So does that change your algorithm or your thought process?
But if you say you clear her to row, and she ends up with all kinds of stress fractures, then can she still go to college and continue rowing, because that's why she's there apparently? So you know, I mean, that's what she's risking.
Especially if it's a recent stress fracture.
Right. And
It's not ideal.
like depending on her position in the boat. So,
If you don't clear her, she'll also just go to a different, she'll find a way.
she might. She might.
If that's her, if her goal is, if she's going for like a collegiate athlete, like she worked her entire like high school career. That's what she's doing. That's her scholarship. I feel like it'd be better to clear her with like parameters and to talk with her and be like, okay, I'm gonna work with you like once a week, once every time. Let's do this systematically so that you can at least have an eye on her and like follow her trajectory.
Yeah, it's like a harm reduction
Right.
model. Yeah, no, that's a great idea too. Yeah. Great, thank you. Yeah, it's a risk-benefit discussion, of course, and really trying to understand who is this person, what's motivating her, what's her timeline, what stresses is she under. There are published indications for DEXA in young people. So this was published by a group of sports medicine physicians in 2014, sort of if a person has high risk factors for low bone density, then getting a DEXA if they are greater than or equal to 2 moderate risk factors. And how do we interpret DEXA for young people? This is just a reminder. So if you're under 20, we should be scanning the whole body or the total body less the head in addition to the L-spine. If they're 20 or older, then it's femoral neck and L-spine. And in either case, for premenopausal girls or women, to use the Z-score, not the T-score. For postmenopausal women, we use a T-score. And the lowest score guides treatment. How do we interpret her DEXA? So what's the definition of low bone mineral density in a premenopausal woman? The published definition is a Z-score of less than -2, less than or equal to -2. However, the American College of Sports Medicine reminds us that we should expect that a female runner, someone who's doing high impact sports, should actually have a higher bone density than -2. So they encourage us to use -1, as was the case here. Osteoporosis is a Z-score of less than or equal to -2 and clinically significant fracture history. I find this framework to be really helpful, and this is in your syllabus as well for your reference. If, in case you come across a case like this, I just really like this tool, which allows you to kind of count up risk factors and risk stratify your patient to say, well, how risky is it for her to go back? How likely is she to get re-injured or get an illness? And this helps you go through these categories. All right, what's her dietary situation? What's her BMI? What's her menstrual period history? What's her bone mineral density? And what's her history of fracture? And so you can kind of come up with a score. In this athlete's case, her score is 5. And then there's another table in this paper that helps you decide, okay, what clearance am I going to do? And based on her risk score, she's a 5, so she's a moderate risk for having another injury or illness. And I think as you articulated, you would want to have a plan with this person. You might clear her provisionally to do some stuff, but it's not going to be just full steam ahead. She needs some treatment, or more evaluation and treatment. The REDS consensus presents this sort of green to red arrow as the same concept as really identifying risk factors for ongoing problems in a student athlete or a young person or anyone really facing REDS, and looking at primary indicators for REDS that are high risk. The more of these you have, the less likely you would be to clear the person to participate. Secondary indicators, so a little bit less concerning. You might clear this person, but keep an eye on them. And really, as was discussed, the treatment is to increase energy availability. Easier said than done for all of us who've taken care of folks in these situations. So to increase dietary intake, decrease exercise. This has been shown to restore the menstrual period. It has been shown to increase bone density. Often these patients benefit from a multidisciplinary approach, and this is a very gradual approach over months. In athletics, we often do have like a contract or an agreement with the athlete so that the expectations on all sides are super clear and the athlete understands what we're doing, what the timeline is, and what the expectations are for their participation, both in sport as well as in their healthcare. All right. That brings us to the end. So I told you that at the beginning of this talk, you'd be able to list 3 screening questions to ask all girls and women presenting for their PPE. So we talked about history of bone stress injuries, we talked about concerns about weight, and we talked about amenorrhea. We talked about labs to order when evaluating secondary amenorrhea, so remembering prolactin and thyroid, and then of course FSH and estradiol. We talked about REDS and the definition being low energy availability, the indications for a DEXA in an athlete, mostly being high risk for bone stress injury, anything that contributes to that. And then injury factors that would make an athlete with REDS high risk for injury and illness, same idea, amenorrhea, eating disorders, stress fractures, and so on. And wanted to leave you with some resources, so I wanted to ask you to save the date. Our annual head-to-toe sports medicine conference, this is for physical therapists, athletic trainers, PCPs, will happen in San Francisco in December, this year, December 4, 5, 6 at the Hyatt Embarcadero. So wanted to invite everyone to attend. And if you're not already using our rehab website, please do share with friends and family if you're looking for like, hey, this is some rotator cuff rehab that will help you, or hey, here's an ankle sprain protocol. We have that posted for you online. We also have a big treasure trove of videos that we post after these courses. So if you are looking to refresh your knee exam or how to do a shoulder injection or anything of the sort, you can search for it here on our Ortho YouTube site. And we do have tutorials about injections and then podcasts as well. So I did a couple Curbsiders. Those Curbsiders is an internal medicine podcast, and I did a topic on shoulder and knee, and there's some great ortho topics as well, given by Ted Parks, who's an orthopedic surgeon and a great teacher. So if you're interested in listening to some ortho updates as you drive, tune in here. Oh, and there's a concussion one as well. So appreciate your participation and your attention. Thank you so much.